So, vision issues. If the child is born with problems with vision, there are a couple of indicators which should cause concern. I call them the high-risk signs of vision loss, and they are quite easy to see or to notice. And often it's, unless the child is diagnosed with charge very quickly, in which case the eye people should be brought in very early and the eyes should be examined very carefully. If that doesn't happen, it might well be a parent or a family member who first starts to realize that the child isn't seeing properly. And those high-risk signs, I think there are four main ones. First of all, an atypical appearance of the eye. The eye doesn't look normal when you look at it. It's too big, it's too small, it's clouded over, it's badly turned, or there's something about it that just doesn't look right. The next one is unusual eye movements. Maybe the eyes keep rolling to the top of the head, or maybe the eyes wobble very quickly from side to side or something like that, which would be very unusual. The third one is unusual gaze or head positions. If the children seem to look under things or over things or to the side of things rather than directly straight at them, that could be an indicator of possible vision loss. And the last one is the absence of visually directed behaviors. And usually the classic first one is the absence of eye contact. And that's why parents and other family members are often in the best position to notice that there's something wrong with the baby's vision if it hasn't been picked up immediately by the medical professionals. I'm going to show you a cross-section of an eye, which might seem a bit surprising to you, and it might seem a little bit basic, but I'm always surprised how people don't really know what eyes are and what shape they are and how they're made. So if you look at this cross-section, the front of the eye is on the left side with the cornea and the lens, and the back of the eye is on the right side, and you can see a line going away out of the diagram, which is the optic nerve, and that's going up to the brain, to the visual cortex. And I'm going to begin by starting at the front of the eye and working back. So the very first thing I'll talk about is actually the eyelids, not even the eye itself, but the eyelids. Then I'll talk about the lens at the front of the eye. Then I'll go to the back of the eye and talk about the retina, which lines the whole back of inside the back of the eyeball and is crucially important for visual perception and visual functioning and can be very problematic in charge. So remember this diagram and remember that the whole point of the eye is that the front should be clear. Light comes from the world outside to the eye. It's conducted through the cornea and through the lens, and it travels across the eye then, which is filled with clear fluid, onto the retina at the back. The retina receives these images, converts them into electrical energy, and sends those messages through the optic nerve to the brain, where the brain puts them together as visual images, identifies them, and then decides what to do. Is this something I know or something new? Is this something I like or something I hate? Is this something I want to go get, or is this something I want to move away from, or something I want to bite, or whatever? So starting at the very front with the eyelids, charge has, many children with charge have a condition called ptosis, spelt P-T-O-S-I-S. And in almost all cases, the ptosis comes from facial palsy. Because of cranial nerve problems, many of the children have facial palsy. Usually one-sided, I think, though it could be both-sided. And often one side of the face is rather collapsed and the other side of the face is fairly normal, or might even be a little bit stretched by the one side of the face collapsing, the other side gets a little stretched. And there can be two kinds of eyelid problem. In this picture, you see a girl with ptosis, and you can see very clearly that it's her left eye where the lid comes down too low. And when she opens her eyes, that eye doesn't actually open. Even though she's opening her eyes, the facial palsy means that the lid is not coming up to allow any visual input into that eye. And when this happens, surgery might be needed. And the surgery can be one of two things. And I can't find any pictures charge specific. But here you see, if you look at the picture on the right of the screen, the before and after picture, you see a lady who clearly has ptosis in her right eye. What they've done is surgery to the upper eyelid. They've cut horizontally across the eyelid, taken a very narrow slice of it out, stitched it back together, and now she has a smaller eyelid, which you see in the after picture now opens normally when she opens her eye. And this is sometimes done with children with charge. The surgeon has to be very careful to make sure that after the operation, the eyelid still closes when the eye is closed or when the child blinks, so that the front of the eye is properly protected and lubricated. On the left side of this picture, you see a little metal thing on the top of that person's eye. That actually is a weight, which, if the eyelids don't close properly, can be surgically implanted inside the lens. The weights are often made of gold, and usually there's just one. Sometimes I've noticed there are two implanted along the bottom of the upper eyelid. And I've known a number of children with charge where, because of facial palsy, the eyelid didn't close properly, and the child is having to use regular drops or gel in the eye in order to keep the front of the eye lubricated and stop it drying out, which would be very dangerous for the cornea at the front of the eye. These eyelid weights are not used terribly often in my experience, and I'm not sure why they aren't used more often. One of the issues, of course, with children with charge is the whole question of general anesthetic and the need to minimize general anesthetic use. And when the child is knocked out with anesthetic, to try and combine as many surgical procedures as possible under one operation. If the eyelids aren't closing, that means the front of the eye is never being brushed by the eyelid to keep it moist and soft. It's exposed to the air all the time, and it's going to dry out unless there are eye drops or gel being administered to the eye. The eyeball itself is very sensitive, and it needs to be kept moist, which is why we blink. It's why our eyelids come down. And as they do that, they're actually smearing the front of the eye with fluid to keep it moist. If it's left dry for too long, the cornea at the front of the eye starts to dry out and starts to wrinkle and will eventually become permanently damaged. And if that eye had normal vision before, the eye will end up with significant visual impairment because of the damage to the cornea. Now, it is possible to get a corneal transplant, to take a cornea from a donor eye and put it into the eye with the damaged cornea. But again, that's a pretty major surgery, and there's a reasonable risk that the eye will reject the cornea. There's very little guarantee that it will work. So it's much more preferable to keep the front of the eye lubricated, but with a child with charge who might not understand the need for the drops, who might not like drops, they might be very protective and oversensitive, difficult to get drops in the eye every couple of hours through the day and sometimes through the night as well, which is why the surgery to insert the weights, if it's possible, and if it looks as if it would be workable with the child, might be a better option. But as I say, it means another major surgical intervention. And I know a number of families who, to avoid that, they've opted for the drops. And I know a number of teenagers and adults with charge who do their own drops very, very effectively and routinely. The next picture shows a cataract. And I think people are very familiar with cataracts, not least because they're more prevalent with age, increasing age. They're also fairly common in dogs and cats as they get older. And what the cataract, what it means is that the lens at the front of the eye, which should be absolutely clear, gets cloudy. It's damaged with time and with age, with exposure to light and sometimes with pressure. And it starts to get milky and cloud, and gradually that person's vision, their visual acuity starts to disappear. And in the picture, you see what doctors would call a very ripe cataract, one that has developed very extensively and become very opaque. And this eye is hardly going to see anything very much, except for some light which will be coming into the eye around the edges of that cataract. And now there's a fairly routine surgery to remove that lens and to replace it with a synthetic lens, which can restore a lot of useful vision to the eye. And those surgeries used to require a hospital stay. Nowadays, people can go in, have the cataract removed, have a synthetic lens inserted, and go home 3 or 4 hours later. Several people in my family have had this done. I used to think cataracts weren't very common in charge, but I'm starting to hear more about them developing. And in the article I wrote about 10 years ago, in about 2010, about vision issues, I said that cataracts weren't very typical of charge, except where children had created them themselves by pressing on their eyes. And it's not unusual to see children with low vision pressing their fingers or their knuckles into the eye to self-stimulate. We think that when they do that, they're probably creating electrical impulses at the back of the eye, which look a bit like fireworks or lightning going off. And this constant pressure creates a traumatic cataract. The pressure on the lens eventually damages it, and the cataract results from it. The surgery is a risk because other parts of the eye in a child with charge might not be normal, might not be perfect. So any eye surgery might come with extra complications. So quite what you do if the eye does develop a cataract would depend on negotiation with the ophthalmic specialist to see the best way forwards. Then the biggie in vision issues in charge is loss of visual field, where parts of the visual field are blurred or completely missing. And the key word here is coloboma. And if you get involved with charge at all, you will start to hear the word coloboma again and again and again. And what a coloboma means is part of the eye which didn't form in the womb. When the child was a developing fetus, most of the charge features happen because the development didn't finish properly. It either didn't start soon enough, or more likely, it didn't finish properly. And I've got 3 diagrams to show a section through the eye and to show situations where the eye stopped developing and a collarbone resulted. So the eyeball, in a fetus, the eyeball forms from the top. It starts at the top and it gradually grows down until you have a complete sphere or eyeball, and then it joins up at the bottom. And the retina is that very sensitive lining around all the sides and the back of the eyeball that's very light sensitive and that picks up that picks up light from the environment and converts it to these electrical impulses. So if the eye development is going to start but then stop, you're probably going to have retina at the top of the eyeball, but not at the bottom. Most of the collarbones we see in charge are towards the bottom of the eyeball. Now, in the first picture, you can see the retina is that red area around the inside of the eyeball. The white spot at the back is a collarbone. That's a place where the retina never formed. And if there's no retina, there's no visual perception. So that will just be a big black area in the child's field of vision. And in this case, the collarboma is right over the macula towards the back of the eye and the optic nerve. The macula is the most sensitive area of the retina where we use our central vision. That's the part of the retina we use to read text. And if you're old-fashioned enough to thread needles, you need good macular vision in order to get the cotton thread through the eye of the needle. You need that fine vision. And in the eye you see in this diagram, that eye will have a very good peripheral field of vision. They'll probably see everything around them, but they won't see that fine area right in the middle of the visual field. So reading text or threading needles probably won't be an option for those people. They might function visually very well in the environment, but they won't be able to read words on the indicator board in an airport or read a book. Probably not, unless they're on something like a Kindle, where they can enlarge the text very, very large to help them use peripheral vision. In the next diagram, you see that a different retina in this eye, the macula is there. You see that brown area that's labeled macula. So there's no problem with central vision. But you notice the bottom of the retina is completely missing. There's a huge white area at the bottom where the retina did not develop. So there's a large collarboma. And that is going to represent a big area of peripheral vision, which is missing. And then in this third picture, you will see again, the bottom of the retina has failed to develop, but it stopped developing much earlier in the fetus. So this is a much bigger collarboma. And not only is the whole bottom of the retina missing, but the macula as well is missing. So this eye is going to have much more severe field loss with central fine vision missing as well as peripheral vision. And I hope that's understandable the way that I've explained it. So let's think about that third picture with the huge collarboma. It's the bottom of the retina that's missing, but it's good to know, and you see this in the next diagram, that when visual images come through the front of the eye and go back to the retina, the image is inverted. As the light goes through the lens, the image turns over and it reaches the retina upside down. So actually, everything we see upside down to the way it is in reality. Once the message has gone to the brain, our brains miraculously turn it the right way up. so that we see everything the right way up. But if you look at this diagram, you see a man on a bicycle, and you notice, of course, he's sitting on the bicycle the right way up. But the image that goes through to the retina has him upside down. The bicycle is on top of him. So if the bottom of that retina is missing, it's actually the top of the image that's missing. So it's the man's head or even most of his body that's missing, and only the bicycle and the man's hands and legs that the retina would be seeing. So a large coloboma in the bottom of the retina results in a major loss of the upper visual field. And people get very, very confused about this. So you do need to remember, if somebody says large coloboma at the bottom of the visual field, that means the child probably won't see things up here. It will be as if they're wearing a hat that's pulled too low over their eyes, and the only way they can see upwards is to extend the head like this and look up. And this head lifting is a very characteristic charge posture for children much of the time. I have a diagram of an ophthalmologist's view of an optic nerve coloboma. He's looking through an ophthalmoscope and he's taken a picture, and you see a large pale area slightly over to the left of the image. That is a large coloboma over the optic nerve area. And I've included this picture to make an important point. When the ophthalmologist looks into the child's eye, they do this by using drops to dilate the eye, and then ideally the child puts their head on the ophthalmoscope, or the child might be laying on the floor, and the doctor will have to be very skillful at getting the eye open and looking into it to get a view of the back of the eye. It helps enormously if the ophthalmologist then gives you a photograph of the coloboma or draws a picture of it. They all have chart paper with two big circles on to represent the left and the right retinas. And they can easily pick up a pen or a pencil and draw the coloboma. There might be one coloboma. There might be several of them. They might be very big. There might be one big one and lots of small ones. It varies a lot. There might be coloboma, both eyes or only in one eye. There's enormous variety. But it really helps to know how big coloboma is, how many of them there are, and where they are, because that gives us a clue about where the field loss will be, where the blind spots will be. So you may need to ask for that, because in my experience, both in the UK and here in the United States, ophthalmologists don't seem to do that very often. It's a simple thing to do, and it can be very helpful for people working with the child into the future. So if, as I've already said, if there's coloboma, the child is probably going to have to look in unusual ways. And the most common is to extend the head back to lift the lower visual field upwards. But they may also do eccentric viewing, as it's called, by turning the head to the left or the right. And the next picture I got only a few weeks ago from a woman with charge who took the picture deliberately to demonstrate eccentric viewing. She has colobomas in both eyes. She's looking at the camera, but clearly, by our terms, she's looking away from the camera. She's looking way over to the side of the camera. And she's just making a point that to get the best visual image she can of the camera, this is the way she has to look towards it. And the worst possible thing you can do to someone like that is to take her chin and keep moving her head back, which I see being done to children quite often. She's in the best position for using her functional vision. And many, many children from an early age discover the best way of looking at things and stick with it. Then the next picture shows a different kind of coloboma. This is an iris coloboma at the front of the eye, which is also found in charge. There might be an iris coloboma with no retinal coloboma, or there might be a retinal coloboma with no iris coloboma, or you might have both in the same eye. And you have a picture of two here that are different shapes. And instead of a perfectly round iris, you've got a whole extra bit. And it's sometimes called a keyhole iris, or keyhole pupil, I should say, I'm sorry. This doesn't in itself cause visual impairment, but it does stop the eye closing down in bright light. The eye can close down to a certain extent, but the coloboma, or the hole, continues to let light in. And these children tend to be very, very bothered by bright light. They don't like going out, they don't like sunlight, and they may well need dark glasses or a hat with a large visor or a sun visor or something like that. The next picture shows a young man I work with, and you can see in the flash photography, you can see very easily which eye has the iris coloboma. And then another young man I know wearing his dark glasses, which have been very important to him. The next vision issue is loss of contrast sensitivity, the relative difference between the lightness and darkness of objects and their background can be very hard to perceive. And this can cause big issues in a situation like this one, for example. You see a set of steps, not very clearly marked. And if the child perhaps only has one eye, so they don't have depth perception, they maybe have vestibular problems, so their balance is not great. And then they've got confusion about contrast sensitivity along with the depth perception. This could be very risky. And then next to it is a different set of steps, which is just as confusing. And then a picture of a meal where somebody's tried to present the food thinking of good visual contrast to help the child with those problems. Now I want to say something about muscle issues. In my article from 2010, I have this quote: "When people think about muscular activities, they usually think of things like aerobics, weightlifting, swimming, hiking, wrestling, and so on. They rarely think about using vision, even though vision is a sense that depends upon very good control and coordination of many different muscle groups if it is to be used effectively."